Thank you very much, Dr. Yarrington. I really appreciate the opportunity to speak with you guys. I got to make sure I get the right PowerPoint up because I just changed it to some degree. Let's see if that's the right one. And the first slide there, you see it?
Yes.
Listen, first of all, thank you all very much for giving me an opportunity to kind of come and speak with you all. I am absolutely delighted to have this opportunity here in Tampa, which is where I've been now for the last 3 years, doing the work that I've continued to do, but primarily as an associate dean here at USF College of Medicine, and also having an opportunity to kind of work with my good friend and colleague for 35 years, Dr. Charlie Lockwood, who is here as the Dean of USF. And so that basically is what I do in my daily work. But as you all know, I've continued to stay very engaged in the space that we live in, and that is maternal child health. By way of disclaimer here, I actually am currently the co-PI for the Alliance of Innovation in Maternal Health Postpartum Community Care Initiative, which is part of HRSA. And the other disclaimer is that I was the evaluator of the Healthy Start Grant in Indianapolis from the time that I lived there until the time I moved to North Carolina for 2 decades. And I really just stepped out of that role in 2018, believe it or not, but still stay very close to my Indianapolis community. So with that, I'm not sure, I'm going to go through these rather quickly. I don't know how much time that I have here, but I can certainly do this in 30 minutes. I'm going to share with you some thoughts on a topic, and you will have these slides that I've kind of given in different ways. And as Bob said, during my presidency for ACOG, my focus was on postpartum care and on telehealth. And of course, I was on the Hill at least 6 times doing maternal mortality and maternal mortality review. So we are very excited about the things that have occurred over the last couple of years, including, Maternal Health Awareness Day nationally, which started out of District 3 of ACOG. We are very proud of the fact that we were able to achieve maternal mortality reviews for every state through the legislation that was done. And now we're very proud of the fact that the piece of this is coming together, at least under the Biden administration, is the idea that extension of Medicaid to 12 months, which has been something that we've talked about now for 3 years, even though we couldn't get every state to expand Medicaid, we hope that we'll be able to get the states to extend Medicaid. And as someone has already alluded to, 50% of all births in the United States are to women on Medicaid. And so we have work to do. We have work to do with regard to that. And so my biggest issue, of course, is that only 50% of women who are on Medicaid achieve their postpartum follow-up. And so one of our goals was to redefine postpartum care so that would happen. And now that we got extension of Medicaid, we have to really pay attention to long-term health. So that's a long road there. But here's what we're going to talk about today. I talk about vulnerability because we could avoid about 40% of all maternal deaths if all women had access to quality health care. It's not how many visits you have, it's how many quality visits you have. All care is not quality care. And so the idea is we have a higher maternal mortality rate in Canada. It is the #1 reason for women being hospitalized in the United States. And for every maternal death, there's about 50 to 100 near-miss morbidities. And this is a group that we're most interested in following up postpartum. If a woman has had a severe hemorrhage, if she's had preeclampsia, we want to follow the guidelines because 1/3 to 1/2 of all maternal deaths occur postpartum, and many of those occur within the first few weeks postpartum. Almost all thromboembolic deaths occur within the first 3 to 4 weeks postpartum. This is the reason it's so important for people to have the appropriate follow-up, and they've already alluded to Black women are going to die at a rate 3 to 4 times higher than white women in the United States. And I want you to hold on to that thought. This is where we are as of the last bit of data. I'm doing some work also in Native communities right now because the second highest maternal mortality rate is in the Native community. I am very excited about the fact that Dr. Marty Tucker, who has just been inaugurated as the president of ACOG, has made Native American obstetric care one of his initiatives to bring consultation, particularly high-risk maternal fetal medicine consultation and collaborative care to the Native community. I was just on the phone this past week with one of my colleagues in South Dakota, and we are looking for a Native site for our community care initiative AIM project. And so we're thinking about trying to figure out how to use that community. But Black women, 42 per 100,000, and Native women, and you can see how that number goes. I want you to hold on to that 40 per 100,000 to 42 because it's going to be very interesting. So I just did a paper not too long ago on looking at reproductive health disparities. I wrote it along with some colleagues of mine and actually presented it at ACOG, believe it or not, as part of the Benson-Hera historical lecture series. But in 1920, approximately 1 Black physician for every 3,000 Black people. Keep in mind, there were 4 million people released, from bondage in 1865, 1866. There were no Black physicians, obviously. And of course, this is what we have. And of course, in 1920, 1 Black physician for every 3,000 Black people compared to 1 in 500 white people. And so most of the births were attended by the majority of granny midwives in all of the Confederate states. I will have one disclaimer. My mother's aunt, my great aunt, was a granny midwife in Eastern North Carolina for nearly 60 years. And I've actually met people that she delivered back in the day. And it was amazing to kind of interact and just know about her as a small child, because my mother talked about her quite often, and so forth and so on. Look at what maternal and infant mortality was in 1900. You can see what had happened and with regard to maternal mortality falling in about 1950. And then, of course, this is infant mortality that had a similar rise. Being a product of the 50s, I came out of Eastern North Carolina. I'm just saying, I'm just happy to be alive. Just happy to be alive. Just happy to be able to contribute when you consider what maternal mortality, infant mortality rate was around the time that I was born. And this is overall, this is not Black rates. When we begin to look at data here for maternal mortality, I want you to hold on to this number, because when you look at Black maternal mortality dropping as it did in the 50s to about 100 per 100,000, and in 1970, where it was about 50 per 100,000 in the 1980s, and think about where we are now. We're at this number of 40 per 100,000, which is just not changed very much, and in fact, is going in the wrong direction. When you begin to look at what was happening in the 1930s and 1950s with shift from hospital home births to hospital births, better obstetric care and so forth and so on, we're still looking at significant maternal mortality in the 50s and 60s. But this is where the disparities began to show up. Really around 1950, look at what happened here. And this is what we're continuing to deal with this 3 to 4 times higher rate. And you have to ask yourself why. In the richest country in the world, why is this the case? And this is a question that I've been dealing with in the world of maternal medicine for the last several decades. Notice I said maternal fetal medicine, even though I'm a maternal fetal medicine specialist. My whole practice was taking care of women with heart disease, with diabetes, with et cetera, et cetera. And this whole passion of mine is there. This is the paper we actually wrote that was published in the NMA journal in December, looking at Black women's health and equity, the origin of perinatal health disparities. And I talk about the fact that poor quality care plus poverty from the time of slavery and growth restriction and prematurity and the fetal origins of adult disease and the stressors really, 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 really impacted what is now occurring with Black infant mortality and Black maternal mortality. Think about it this way, and even in current times, when you think about infant mortality and maternal mortality, if you are worried as a Black mother about your teenage son not coming home from driving to work or wherever, think about those stressors in your life that are generational, that ultimately impact your infant outcomes and your risk factors. And so we took that perspective in looking at this presentation. This was from Circulation, published in December. It looked at the call to action from the American Heart Association. I've done some work with them on talking about structural racism as a fundamental driver of health disparities. This was the presidential advisory. And this is a chart that they put together that actually showed to the legislature when I was doing that presentation. Race is a social construct. Racism has multiple different definitions, as you know. Social determinants of health you all deal with, but all of these things, socioeconomic position, I'm going to talk a lot about poverty and how it impacts those type of things. But I'll send you, you'll have this paper because these definitions are very important when it talks about health disparity as opposed to health inequity. Health disparity, health differences that are closely linked to social, economic, environmental disadvantage. Health inequity are systemic differences in health status of different population groups. These inequities have significant social and economic costs to individuals and society. So when we think about health disparities and health inequities, they're tied together. And they're all tied together to the type of things that I'm going to share with you today. Why is Medicaid extension so important? Why is insurance so important? Because at least evens the playing field to some degree if we could get those things out there. This is the link to poverty. If you are 15% or higher, your maternal mortality rate looks like the red line. And that's regardless of your racial ethnicity. But we know it's different depending on your race and ethnicity when you tie all the other factors to poverty. When you begin to look at the relative risk and people who are 5 to 15% of the poverty level, you can see that that number pretty much stays in this range. This is what was happening in the 70s with poverty. This is where we are, and we look at different periods of time and so forth and so on. And then the poverty rate less than 5%, your maternal mortality rate is quite low. When you look at relative risk of all-cause mortality in the United States, all-cause mortality, men, women, everybody. If you have less than $25,000 a year income, your household income, your mortality rate is here compared to greater than 115. So this is why when we talk about Medicare and Medicaid and Medicaid expansion based on the level of poverty, this is why it makes a difference in terms of overall health. Now, we know that these are the causes of maternal mortality through AIM and through the things, all the great work that's been done in Florida that we can do things about. We've been able to deal with hemorrhage, we've been dealing with embolism, we've been preeclampsia and sepsis through our AIM bundles that are incorporated in your hospital. And as a result, maternal mortality rates in Florida have clearly gone down for hospitalized women. These are the things that we have not been able to do a lot about. Motor vehicle accidents, homicide and domestic abuse is one of the leading causes of maternal mortality in Black women. Suicide is a leading cause for maternal mortality in white women. And substance abuse and overdose, you can see what role it plays in maternal mortality. We didn't want to concentrate on these things on the legislature because we really wanted to focus on those things that the legislature could get. It's not that we want to ignore these things, because these are major things that would happen in the postpartum period. And we have to be dealing with those with regard to infant mortality and maternal mortality. But these are the things that we've been able to concentrate on through AIM in hospital bundles, et cetera, et cetera. But the thing that we've identified is clearly that most maternal deaths are preventable. Preventable. Cardiovascular disease, we know that we've identified, I'm working with a cardio-obstetrics group right now, women who are over 45 who are having births have a greater risk for mortality from cardiovascular disease. Working on a paper right now with one of my colleagues from Boston that's looking at women who are undergoing IVF. And the fact that what is the minimal cardiac workup they ought to have. Preeclampsia, we know that those women ought to be seen back in 72 hours or 7 days. Postpartum, to prevent them from showing up in the emergency rooms, as Dr. Everton and I talked about our maternal mortality committee a lot of times. We live in a rural state. They're showing up in an emergency room somewhere in heart failure and being treated like a man from the VA, as opposed to being treated like a woman who is postpartum. Then obstetric hemorrhage, we should be able to prevent the majority of those deaths if we have a hemorrhage protocol. Thank goodness the Joint Commission made a decision that every hospital that does obstetrics must have a hemorrhage card. Every hospital who does obstetrics must have a hypertensive protocol. Amniotic fluid embolia are rare, but they're all deaths. You can see that more than half of those are preventable. Why do I mention Philip Lee? He died very recently. Philip Lee was a champion under LBJ. He was Assistant U.S. Secretary for Health and created Medicare, the federal health care insurance program for Americans 65 and older. What was required was that hospitals had to be integrated in order for them to receive Medicare. Now, Dr. Everton and I are both products of the South, and we know that it was a challenge to get those hospitals to do that. But when you're talking money, stuff starts to happen. By February 1967, nearly 95% of hospitals were compliant. When I trained at Grady, there were 2 different towers. It was integrated, but it was a black side and the white side. We were doing 8,000 deliveries. When I got down to Charity in New Orleans, which Bob knows very well, it was the same way. 2 different towers, even though we were officially integrated. Medicare played a major role in desegregation of hospitals. Medicaid was designed to provide access to mainstream healthcare for low-income women and families. Keep that in mind, because when we think about Medicaid expansion now, look at what the data shows. 32 states adopted the Medicaid principles and Medicare before any of the former Confederate states adopted it. Hold that thought. This is what a Medicaid expansion looked like in 2020. The Confederate states, Texas, which is a Confederate state, a few other states have not still have not expanded Medicaid. And so basically, this is a big deal. So when Florida is extending Medicaid and is the first of the conformal southern states to do that, that's a big deal. That's a big deal. We've got a lot of work to do. Now we have to deliver. We must deliver. We must deliver in a way that we have never delivered before in terms of making sure that those women have the follow-up for their potential chronic diseases and so forth and so on. Maternal mortality postpartum, this is what you all are dealing with and we are dealing with, because I told you that most thromboembolic deaths are going to occur right here. Only 17% occur on the day of delivery, 31%. This is what's happening. And even in Florida, this is where the cardiomyopathy deaths are occurring. The cardiovascular deaths are occurring between 42 and 365 days. That's why extension and follow-up is so important for the most vulnerable populations. I'm going to turn myself to something because this came out of the 2020 equity report. We're actually in Hillsborough County. I now love this place, but I've gotten a chance to play a little bit with the city and the state and the county, et cetera, et cetera. And what I want to share with you is when we look at regional poverty by race, we still are talking about the fact that poverty plays a major role of people who are 2 or more races. In Blacks in Hillsborough County, about 24.3%. We compare ourselves to the other major cities, the major counties. We can see again how our partners are doing. And I say this from the perspective of USF Health, because we have Sarasota, St. Pete, we have these surrounding counties. Poverty matters. When we look at the median hourly wage by race and ethnicity and educational attainment, again, we can see how things look very different as we begin to get up to people who are graduating from high school, with some college, with bachelor's degrees or higher. We can see that we, comparatively, we're doing okay. But when it comes to pay differential, it's still an issue. I'm in the equity space. I'm looking at equity all across the board here at USF and so forth. So now when we look at the Black-white gap in poverty, you can see that it's about 13.7% here in Hillsborough County. So you may want to know why I'm telling you this. I'm telling you this for a lot of reasons. But obviously, when you tie poverty to social determinants, to racism, its impact on what you're trying to do with maternal child health matters. So when we look at state-specific maternal mortality rate, which I showed to the legislature, one of the things that's clearly one of my concerns, of course, is the disparity in cesarean delivery. The percentage of deliveries to non-Hispanic Black women is still the biggest determinant of maternal mortality, along with unintended pregnancy. Unintended pregnancy. 50% of pregnancies are planned, 50% are not planned. I would say that maybe more than 50% are unplanned. And then when you begin to look at these factors, they play a major role in every state's maternal mortality rate, including Florida. One of my passions is gestational diabetes. I want you to look at this very carefully and why it's so important now for us to use the postpartum, the extension of Medicaid the way it should be done. And Dr. Yeverton is a tremendous OBGYN, his practice, all of our colleagues. But look at this data. We know the reason that we screen women for diabetes is to predict their long-term risk for developing diabetes, not about them having a big baby. And so we've recommended that women have a postpartum glucose screen at 4 to 12 weeks postpartum. But here's what the data shows, and this is why we aligned it with our postpartum follow-up initiative. In this study published in 2016, 500,000 women across 50 states, 7.2 had gestational diabetes, 75% had no follow-up for their diabetes within a year. Diabetes is one of the leading causes of cardiovascular disease. What is the failure? 50% of women are not showing up for their postpartum visit. We got to do better. But when they show up, we certainly need to screen the diabetics. And that's what the state is going to require us to do, because they're convinced that the reason that Black women have a higher maternal mortality rate because they got all these comorbidities. That's not necessarily the case. We've got to prove that this is going to be something we're going to do better. And in this study, published in 25% received any kind of glucose screening 6 months postpartum. We have to do better. So when you look at contributors to health and healthcare inequity, we know there are system factors. We know that there are patient level factors, beliefs and preferences, race, ethnicity, culture, family. I don't need to go there with you. Just think about the people who don't want to take the vaccine. That's another whole chapter. I spent an hour this morning talking about that. Education and resources. And I'm talking about biology because the stressors that infect the cytokines that in fact are related to prematurity and also related to heart disease. The uterus is a smooth muscle just like the heart. A stressed heart causes heart attacks. A stressed uterus with inflammatory cytokines leads to prematurity, and how we handle those stresses. Clinical encounter. If the person at the front desk is not patient friendly, you get a bad experience. I had 5 neighborhood health clinics in my network at Indianapolis as part of my Healthy Start program. And really it was a matter of just the person who worked at the WIC office need to not be angry with people because they were coming in to get WIC. She needed to get it together. And I had to have a come to Jesus meeting many times with people to say, why are you upset with the people if they're coming in? Why do you work at the WIC office if you don't want people to come in to get WIC? And this is the reason that an equity survey is part of our assessment of all those individuals in the AIM Community Care Initiative. Provider communication, provider factors and knowledge, structural factors, and there it is again, racism. The things we're concerned about in Tampa, food security, stability of housing, unemployment, poverty and wealth. These are the social determinants and how you are treated in the system. So this is what we wrote. Elizabeth Howell and I wrote this paper looking at the disparity bundles for peripartum disparity bundles that was added to the obstetric bundles. And we came up with this graph here. Understanding racial disparities is a big picture. Certainly there's culture, there's literacy, there's language, fragmentation of care. We're not practicing the medicine that my mother received, even with the midwife back in the day, and even by the doctor who delivered me. She saw the doctor, he delivered her, he saw her afterward, et cetera, et cetera. That's not the system now. Federal qualified health center clinics, multiple clinics, fragmentation of care. You meet the doctor for the first time in the delivery that you never met before, and then who knows who sees you postpartum. Now, in a wonderful group practice, we used to have at Duke and other places, is we made sure that patients saw all of us over the course of time so that she would get to know who her provider was going to be. Education, poverty, institutional racism, environment, all play a role, comorbidities, biases, et cetera, in the disparity that we're dealing with. And we know that's the case. That's why your community work is so engagement. Now, those are people who know me from my Healthy Start days in infant mortality in Indianapolis know I've been into fathers. And I've always worked with groups of fathers. The paternal participation in and understanding pregnancy and the birth process is important to a healthier childbirth experience for the couple and birth outcomes. So I talked a lot about the expected father, and in fact, I used to teach new fathers boot camp, which is actually we pulled that from the Colorado Denver Healthy Start program, and the father's attitude about breastfeeding has an impact on the mother's decision, as well as her contraceptive choices. So important to include the fathers. And I'm now, it's all about inclusion, or the partner whomever it is who's considered to be the support person for that expected mother. Expected parents are often ill prepared for pregnancy complications and their impact on maternal infant outcomes and well-being include prematurity, preeclampsia, birth defects, and postpartum depression. And I had a father call me one day when I was still practicing in Indianapolis. His wife had delivered their IVF twins. He called me about 3 weeks out and said, something is terribly wrong here. I'm not sure what it is, but I think my wife is really having a breakdown. We brought her in, we had to admit her. Her depression was so severe and she was treated and she did okay. But again, this is why it's so important for fathers and parents and people who are taking care of the pregnant woman to understand. And we know that women of color have a significantly higher risk for postpartum depression, except we don't identify it. We don't identify it, and we have to do better. If you look at this paper by Alio, it looks at fathers and the association of fathers and birth weight. Lower birth weight with the father present, Black mothers and the fathers present, versus Black mothers and the fathers absent, versus Hispanic mothers and the father present, versus Hispanic mothers with the fathers absent. And the same thing holds true with very low birth rate, with prematurity, very premature. Look at the difference with the father present and very premature versus the father absent and very premature. Not my data. It does make a difference. Reading to your children. This is my new campaign. We start reading. Why do you play the carousel to the baby with all the beautiful songs and things like that? And why are people doing these things and reading to your child in utero? Powerful. I'm doing a program right now called the 0 to 3. You all may have heard of it. It's a home visitation program. Just did a talk for them last year for the feds. Part of the whole HRSA initiatives. Families and schools and communities all have a role to play to ensure that every child receives a lifelong advantage of literacy and early learning before an achievement gap is created. So we're now dealing with the fact that we want to do better because third graders who cannot read on a grade level today are on track to be our nation's lowest income, least skilled citizens. I could show you the Hillsborough County data on reading scores. I didn't do that. Some states use elementary students' reading failure rates to predict what? Future prison size. Richard Nixon built prisons, for-profit prisons, based on what the Black male birth rate was gonna be. Now he did Title IX and Title 10 as well, which is family planning. He signed into the law. Actually, that was George Bush who actually did most of that work. But the reality is, he did it on the backs of the welfare mom. But we're not going to look a gift horse in the mouth anymore because a contraception, an affordable contraception for all women is now a right. And so, again, for birth to age 5, when a child's brain is developing rapidly, it's time to build a foundation for cognitive ability and character. So this is why I'm talking about reading to your children. I don't care what you read to them. Read something to them. Read to them. Institutional racism in the healthcare system. This is from the American Academy of Family Physicians. Recommend that all healthcare systems, hospitals, clinics, institutions adopt anti-racist policies that advocate for individual conduct, practice, policies that promote inclusiveness, interdependence, acknowledgement, and respect for racial and ethnic differences. Martin Luther King said this in 1965. Of all the forms of inequity, injustice in healthcare is the most shocking and most inhumane. That's the quote. That's why we're concerned today with the 42 per 100,000 Black maternal mortality rate, which is what it was also in 1960. But the rate in 1950 for all women was only 42. Now we're looking at 42 still for Black women. Not right. I want to taunt these things because people are on the stage there, and I'm on the Merck for Mothers board. I didn't have anything to do with this, but this is exciting news for you all in Tampa, because the Safer Childhood Cities grantees were engaging communities to address social determinants of health that contribute to disparities in maternal health outcomes, such as access to care and health literacy, many city-based programs. And you can see, there you all are, reach up, selected as a safer childbirth city. Now my goal is for Tampa to become a AIM Community Care Initiative city and county. So put that under your hat. We have to have 25 cities by the end of the next calendar year in different states. And this is where you all come in. So I'm a little selfish. I also look at things for where I'm living. The impact of COVID outbreak on minority health and health disparities. These were the NIH grants. We see that Florida and Central Florida had a pre-pandemic evaluation of discrimination in 500 Black pregnant women. This was part of the COVID NIH stuff. So Florida's doing its part. So when I think about population and health disparities, as I'm finishing up here, racial and ethnic minorities are defined by census, less privileged socioeconomic status, underserved rural residents, sexual and gender minorities, health outcomes that is worse than these populations compared to a reference group defined as a health disparity, social disadvantage that results in part from being subject to discriminations by race, being underserved in the healthcare system. This is what we talk about with population disparities. How do we mitigate racism? Supportive parenting, early childhood education, physical activity, racial socialization and supportive relationships, integrated experiences, social cohesiveness, interaction, religiosity, mediation, meditation, mindfulness, cultural competence. Not everybody is culturally competent. My WIC worker was not culturally competent. And you may have some people who are not culturally competent too. You have to identify them in your system. 99% of prenatal care is caring. 99.9% of prenatal care is caring. Cultural competence and patient-centered care. Power and structure of institutions and policies. Policies can only do so much. People have to do the work. Finally, 400 years since the first slaves arrived in America, health disparities are rooted in generational stress of Black women. Generational stress. Prematurity, growth restriction, maternal morbidities, the fetal origins of adult disease, and fetal growth restriction that leads to diabetes, hypertension, and obesity. The uterus is just another smooth muscle. If these factors and generational stress have affected outcomes through generations, is it any surprise that cardiovascular disease are linked to these things? And adult cardiovascular disease is clearly tied to the fetal origins of adult disease. So we've got a lot of work to do. And thank goodness we have an opportunity to do it if we care and we see those women in the postpartum period. So this is what I wanted to share with you all today. I'm so excited to be in the city of Tampa and in Hillsborough County with you. And as you all know, I'm passionate about the things I'm passionate about. And as Bob would tell you, this is my work coming together. And that's the end of my slideshow today. I know I've gone through it quickly, but you can have these slides I'd be happy to answer any questions if we had time for them, and so forth and so on.